Well, President Trump has been building a beautiful wall on the Mexican border to keep out immigrants. We've got a beautiful blue wall here on the Canadian border to keep out universal health care.
Tear down that wall. Universal coverage is coming, David.
Welcome to CareTalk, your monthly home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix.
Well, John, you remember those litmus tests? Medicare for All is quickly becoming a litmus test for presidential candidates on the Democratic side. What do you think of it?
Well, it's less of a litmus test than sort of it's a brand extension to cover any new proposal around coverage. It's really not Medicare for all. It really reflects the scream inside anyone who has to deal with the challenges of coverage and cost for affordable coverage for all Americans. I wouldn't get hung up with all of the details, but what it really speaks to, when 3/4 of America is somehow supporting a general Medicare for all, it means that the vast majority of Americans want affordable coverage for everyone. But I think it probably means also much more of a public-private mix than you're hearing about. What do you think?
John, I think Medicare for all is a good label. People like Medicare. Remember in the Affordable Care Act, people came out and said, hands off my Medicare. Mm-hmm. People like Medicare. And I think it's much better tag to have on you rather than, socialist or universal coverage, universal care, or, national single payer or something like that. When the Democrats get into trouble is when they start talking about eliminating private health plans or putting people on Medicaid.
Details. The reality, David, is that Medicare today is a public-private mix with private doctors and private health insurers in Medicare, managed care, which is working well as fee-for-service. The reality is it is a system that works. And the reason why people like it is access, coverage, some amount of transparency, and a mix of public and private. So I think when people are asking for Medicare for all, they're really asking for the kind of choices, options, coverage, and support that they get in all the different forms of Medicare that exist right now.
Well, we'll have a chance to disagree a little bit later, but I got to agree with you here, John. I saw a tweet that actually talked about, which would I rather have? Coverage that something that pays for everything all the time compared to what I have now, something that sometimes pays for part of what I have. So I think it's a good slogan. You should keep using it, and it's going to bring them right to the White House.
Those tweets, because that was confusing, David.
I should stop reading it.
So,
yes.
David, what do you think of this big move with home health agencies around kind of home-based primary care?
I mean, John, it sounds great. Doctor whatever is going to come to my home and help me out. But let's face it.
Why are you so skeptical?
I'll tell you why, John. Because what is this? What is a scarce resource? It's the doctor, right? So you have a shortage of doctors. So have the patients come to them. I know it doesn't look great. Have them wait in the waiting room instead of going around, from stuck in traffic from one place to the other without their bag of stuff.
David, normally you're a futurist and you embrace the future, but the reality is
tomorrow.
Primary care and all of the breakdowns in coordinated care, a lot of them, particularly for chronically ill folks, can be helped with primarily primary care and care coordination happening in the home. There are a lot of homebound seniors. The Independence at Home demo, which was a big bipartisan support of innovation, which doesn't always happen in American healthcare, has saved 10 times as much money on a per patient basis as the Accountable Care Organization initiative, which was also a big bipartisan initiative. It's saving on nearly $3,000 per Medicare participant per year. And that's just not dollars of savings. It represents a significant improvement in the health of those folks who are chronically ill, who are getting care. I think what you're going to see is not just doctors going to home, but nurses, certified health aides, a lot of technology, all starting to provide a supportive web for care in the home. That's where the future is, and you better embrace it, or you'll be left behind.
I don't want to be left. No child left behind. But
no chronically ill person left behind or outside the system. Care is coming to even your home, David. You're looking kind of old by the moment.
I'm going to put an extra lock on my door to keep it out. John, I'll tell you what. I'll say if regular home visits of doctors, I think, isn't going to work.
Oh, you're backing
It's going to be too expensive. If the technology is there, and if the protocols are in place, and if you leverage nurses and nurse practitioners, then maybe you can do it.
You're a Luddite.
Thanks,
Care
John.
to the home is coming.
The Luddites weren't really against technology, were they?
Well,
all right, John. So fine.
Yes.
Now, how about, I have an evil one for you, John. Drug rebates. Finally, the government is saying, crack down on those PBMs and their ridiculous drug rebates, and that should take care of healthcare. So do you think
that's what's driving up pharma pricing?
That's my understanding.
So you think that the people who are negotiating the discounts off of the prices that pharma is raising every month, Pfizer, 140 drugs last month, pharma drives those prices up. Somehow the people who are negotiating the discounts are the problem. Like, look, there's clearly a problem when the entire system is untransparent in healthcare, and the rebates have not been handled in enough of a transparent way. But if you think that the people raising the prices, big pharma, are not responsible for high prices, you're just a tool of them.
I'm a tool of the establishment, John.
You are. And there's all of this conversation about pharma rebates is being driven by a secretary of HHS who has done some great things. But on this one, he's just being the long arm of pharma is crawling its way through policy. The real problem here is Americans pay too much for drugs. Everyone knows it, and the PBMs are just noise and a side part of the system.
They're just noise, and they're making a lot of money from it. John, I find it offensive that someone's going to decide what drug I'm going to get based on what rebate they can negotiate. And you know what? The rebates are going to somebody other than the end patient who's actually generating those rebates. A poor guy or a woman is going to be paying a bunch of money for stuff.
The proposal to create more transparency and to provide rebate discounts at the point of sale is a really good idea.
Okay, thank you.
And I think that's going to, but to be drawn into this notion that somehow that's going to affect, by providing direct discounts to the chronically ill, is going to affect the prices that are going up every month based on pharma jacking up prices and extending patents and leveraging the system to keep a price level that is higher in the United States than any other industrialized country. You're helping prop up a system that's beggaring the American patient. This proposal is a good one, but let's look at the problem here. Americans are paying too much, and we're not, and we've got to have someone like the federal government start to hold the folks who are generating these monster profits from pharma responsible for reducing those profits and genuinely reinvesting in the health of Americans.
Well, John, maybe if you gave me a rebate, I'd be willing to agree with you. So, John, the lightning struck again with the Patriots, as we predicted, winning the Super Bowl.
Yes, but we always predict the Patriots.
We do, but it's a safe bet. How about lightning round? Do you think that could strike again?
I'm ready.
President Trump promised a whopping $50 million a year for childhood cancer. What would you do with all that money?
Big man Trump, a pittance. Cancer's a $96 billion problem. Obama in 21st Century Cures put over $5 billion into the NIH to help cure cancer, kill cancer, save cancer. This is a joke.
Listen, for $50 million, I think you could hire LeBron James and take 2 trips down to Mar-a-Lago.
1 trip down to Mar-a-Lago. So, David, I know you're watching all those drug ads while you're kind of spacing through the daily soaps. Now, we're actually going to have the full drug list price in the drug ads. Do you think it'll make a difference?
Well, John, I love those drug ads, as you know. My favorite part is the side effects. Blue urine, hallucinations, compulsive gambling. So why not just add the price tag and $25,000 as well? I can't tell if that's because of hallucination or what. I don't think it'll do anything, John.
0.
John, Donald Trump said he's going to end HIV transmission by 2030. Well, where's that coming from?
David, where does anything come from the Donald Trump? What say you?
You know, I remember back when he was speaking with Howard Stern in the late 90s, and he compared avoiding STDs to his own personal Vietnam. So I think maybe 2030 he's going to be out of prison, and he will be wanting HIV to be done by then.
He missed Vietnam. He's probably going to miss this too.
Red Sox, Patriots. We predicted the last 2 big winners. Should we predict the Celtics and the Bruins winners too?
Red Sox, Patriots. Let's quit while we're ahead.
Actually, let's get Belichick in there to coach the Celtics, and maybe they could win the World Series.
Go Sox.
Well, that's it for yet another edition of CareTalk. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for watching. Hey there, listeners. Want more Care Talk? There's more to be had in our other episodes, so be sure to look for those and subscribe to Care Talk on your favorite service.